This is a case study of a 67-year-old male with chronic symptomatic degenerative osteoarthritis. His symptoms have been refractory to non-operative treatment. His total arc of motion was 5 degrees of hyperextension and 140 degrees of flexion. He underwent a primary cruciate retaining total knee arthroplasty, but by 12 weeks post-op, he had a flexion contracture to 5 degrees and maximum flexion to 90 degrees. He was taken to the OR for arthroscopic lysis of adhesions. The examination under anesthesia confirmed range of motion could not be achieved beyond 90 degrees. 3 standard arthroscopic portals were established, and with the knee in mid-flexion, the arthroscope was introduced in the inferior lateral portal, and a shaver was carefully introduced in the inferior medial portal. Granulation in scar tissue was carefully resected to expose normal anatomic landmarks within the anterior interval and the pretibial recess until the patellar button was exposed. The shaver is gradually swept medially and laterally to gain anterior access to the peripatellar tissue and the suprapatellar pouch. The suprapatellar pouch is cleared up to and including the deep quadriceps fascia. It should be noted that the reflection off of the femoral component can make proper orientation difficult initially, and care must be taken not to scratch the implant surfaces with the instrumentation. Here, the lysis is continued medially with a radiofrequency probe, where the space within the medial gutter is reestablished. It is often easy to appreciate the scarred layer between the capsule and the femoral condyle. The anterior portals are used interchangeably for the arthroscope and instrumentation to improve access. Here, the radiofrequency probe is in the inferior lateral portal, and a lateral gutter debridement is performed. A lateral retinacular release can also be done to improve patellar tracking. The knee is placed in 90 degrees of flexion and the intercondylar notch is exposed. Here, the PCL is being detached from its femoral origin as it was determined to be tight preoperatively. The instruments were removed and an examination under anesthesia was repeated. Here we were able to achieve full extension and 120 degrees of flexion. Postoperatively, the patient was placed on continuous passive motion and active range of motion for 6 weeks. At 3-month final follow-up, range of motion achieved intraoperatively was maintained.